Hi, everyone. My name is Joyce McSwan. I've got some really pressing questions for Dr. Enchita Kamakar, whom I'm actually sharing a car ride with at the moment.
Hi, everyone.
Hello.
Hello.
This is a car podcast. Some questions I've been having because I work very closely with GPs. I'm a clinical pharmacist and I run a Pioneer Pain program on the Gold Coast, and there has been just really some questions that have been coming up which GPs are asking. So I would take this opportunity to get some help from Dr. Kamakar.
Yep. And the reason, I guess, why I'm involved is through recent media. A lot of people would know I've been going through this process of audits and so forth, and I guess I'm just here to share my insight on the material. This, by all means, is not legal advice. I'm no lawyer. I'm just another colleague. I'm just sharing my experience. So shoot away your questions, Joy.
Okay, awesome. So I hear that there's a few acronyms I want to run by you.
Yeah.
Because they sound like gobbledygook. And when I ask GPs, or when GPs ask me if I've heard of these acronyms before, I haven't. And
That's right.
sometimes I think it's a clinical term, but it's actually not. So the first question is, there is a certain review process, I believe,
That's right.
that is called PRP by that acronym. So number one, what does the acronym stand for, and what is it?
Okay, so PRP stands for Professional Review Program. So taking a few steps back, any doctor or healthcare professional that bills through Medicare, basically we have a social, responsibility towards making sure that those scarce resources of Medicare money that are given or assigned by the patient to us is, given for clinically relevant and needed care, I guess. And there are certain things in the regulations within the acts and legislation that governs this amount of money that we need to actually meet as clinicians to have the legal right to be able to have that money given to us. So I guess what it is there's we've got the Department of Health, which basically is where Medicare lies, and within that there's the pharmaceutical benefits as well. So the Medicare Department of Health initiated this program where, for whatever reasons like high billings or profiling of high billings, certain people get identified, or maybe the public or your colleagues might identify you as billing a lot for maybe query, I guess what people call dodgy practice, I suppose. Then these people identify you and start with this one friendly phone call from your practitioner, I guess, is where they are technically your peer, who basically are employed by the Department of Human Services, by the government basically, to conduct this initial process of reviewing your practice to see. Initially the PRP is where they would call you, they would then write to you about their concerns, and after they write to you about their concerns, they would then organize a meeting with you, at which point you are then to discuss what your understanding is of your billing.
Okay, so how does PRP pick up on that sort of data set?
Sure, and that's a really good question. So there's a few ways. One is where people can technically dob you in, so your colleagues or your patients or the public can actually sort of identify clinicians that they feel are not doing their job properly. So then that can be a trigger point for Medicare to say, knock on your door. The other way is the data called the NPS data, which a lot of us would receive as GPs in our mail, where they identify, compared to you, the people around you, what are they prescribing. So let's say if you're running like a chronic pain clinic, how like you, Joyce, you've got doctors that are, doing a lot of services that they're giving to their pain patients.
Yeah, like their special interest.
Correct. So those doctors would be at risk of getting identified because that particular data doesn't have any clinical profiling as part of their data collection. So they don't actually say, okay, among the doctors that do pain, do these guys prescribe more compared to those doctors that do pain as a special interest? What they do is they just compare you to the general public of general practitioners.
So does that not deter general practice from subspecializing?
Well, correct. If you interpret it in that way, that's absolutely right. Because essentially, if you're not doing the normal thing that the normal average GP would do, you get identified and you get, rolled into this audit process.
But according to the fraternity of your, GP, RSEGP, and obviously professional development bodies who want to help GPs to have a career path that's of interest to the GP, do they actually encourage subspecializing?
Well, as a matter of fact, it seems like the trend at the moment I can only comment on general practice, it is a trend for doctors to actually subspecialize in that sort of field because it serves the purposes better. But that's the dichotomy compared to what the actual audit process is, and that's where that loophole is.
So if you actually do subspecialize, you may, in fact, be doing yourself a disservice.
Absolutely.
Despite probably being a lot more effective in a particular disease management state that you have interest of.
Correct. That's absolutely right.
Okay, that's really interesting. So can we just go back to that sort of so-called dobbing process, as in how you can get picked up by PRP? Where do they ring? Like, how do they ring? What's the hotline to dob?
It's exactly, it's called the Dr. Dobbing Hotline. If you go online and if you go onto the Department of Human Services site, Medicare, there is a link that actually allows clinicians and doctors and the public to anonymously make a dobbing of clinicians that you feel should be dobbed in for.
So what's the actual terminology that is there for someone looking for this? Is it?
I think it's called medical practitioners conducting. I'm not sure exactly the terminology of Medicare fraud is what they actually categorize it as, which is ridiculous because until proven otherwise, you're not actually doing Medicare fraud.
Sure. Okay. So moving along, there's another acronym that's of interest called the PSR.
That's right.
What is that, and where does that sit under? Is it the same Department of Health sector?
Well, no, technically what it is once the Department of Health actually puts you on the bandwagon of the PRP, so you go through these stages of interviews, writing submissions, explaining yourself about why you prescribe that way or why you practice that way. And essentially, if the PRP panel is not satisfied with your answers, which most of the times they're not, they then have the powers under the law to actually refer you further on to a delegated, company basically called the Professional Services Review Committee. And the first stage of that is referral to the Professional Services Review Director, who basically holds a delegated power directly from the health minister to have the power to get your patient records and look at your clinical notes and come and interview you and ask you to write about it, etc. There's all these different stages you go through, at which point the director then makes a decision. There's three things that can happen. The director can make a decision that everything is fine, so you can move on with your life, or the director can decide to refer you to the Professional Services Committee, which is again it's stage 2 of the process. The third process is where the delegate, so the director of PSR and the doctor or health practitioner in question can come up with an agreement where they agree that they have potentially done a percentage of something that they've done wrong, and they just basically cough up that money. So there's 3 outcomes to that process. Now, when you get to the stage 2 where the director is not happy and you're referred to the Professional Services Review Committee, that involves the committee then asking for a further 25 clinical records per item of item that's in concern. So essentially, it only takes 25 records of the entire whole year of, let's say, questioning for you to be deemed as a rota, a fraud, or a over-servicing doctor.
So how many patients would a doctor see on average in a year?
Well, if you average about, say, 20 patients a day times 5, that's about 100 patients a week times you do your math.
Right, okay. So, but 25 is all you get judged on.
Correct. And then once that 25 is, say 50% of that 25 clinical records are deemed to be, say, inappropriate, purely based on that professional services review committee's opinion, no standards or benchmarks, just their opinion, then that actually gets extrapolated to the entire year's worth of your billing. So 50% of your, say, if you billed $100,000 to Medicare for a certain item number, if the committee decides that 50% of that, of the 25 sample they had, was not good, then that means you have to pay them back $50,000.
And is that a random sample?
Yes, it is randomly selected, correct.
Okay, that's most interesting. And how enforceable are those rulings?
It's absolutely enforceable. It goes to the stage 3 is where it goes to the determining body. They have statutory powers to enforce that civil penalty on you. They not only have the statutory power to enforce the civil penalty, they also even have the right to publicly reprimand you and name you for being the doctor that had to pay back that money because of inappropriate billing. And the worst case scenario, they will take away your right to actually be able to bill Medicare.
All from the 25 and 50% less of that?
Correct.
Okay, so in terms of representation, let's go back to that process that we're talking about. In terms of representation, I'm just curious as to who will assist the doctor, because obviously this legal jargon and this legal process
Very scary.
is very, very scary.
Yeah.
So who supports, in all fairness, obviously the GP needs some support and some representation. So who represents the GP in this case?
Okay, so it's a really good question, Joyce, because this is what I found was the most scary. First of all, you would think that you will have to go to your medical defense agency. And can I say to all of you that are listening, yes, you do have to let your medical defense organization know that you are now under scrutiny for Medicare, etc., because of your non-disclosure, disclosure phrases that's within your contractual agreement with your medical defense agencies. So, yes, you do have to let them know. From then on, they do say that they are there to support you, but unfortunately, the current law that regulates this process actually forbids doctors from having any legal representation as such. So you can have support and you can have lawyers helping you write your submissions, etc., but you can't really have them represent you. And also I found that the medical defense organizations are very reluctant to question the fairness of the process itself, because what that would mean is that you'll have to actually challenge the entire process, which is obviously quite expensive and litigious in nature. So that's one port of call. Yes, you do have to let the medical defense organizations know, but don't be surprised at the level of support you get, which might be quite minuscule. The second port of call, those of you who are members of colleges, professional colleges, or if you are a member of a union, like, say, the Australian Medical Association, which I was a member of for both, to my surprise, the unfortunate reality is they're both conflicted in helping you on an individual basis, because the professional services review committee panels and the directors are in discussion with these professional bodies in how they're supposed to, prosecute you, how, what committee members should be appointed, etc. So you can't discuss your matter with them, and they're even named in the actual Health Insurance Act itself. So essentially, who else do you look for? Well, maybe colleagues, but guess what? The moment you're on that bandwagon, you are actually tainted as a rorting doctor, or that weird, greedy doctor that bills so much that's now in trouble with Medicare. So, to answer your question, Joyce, there's nobody.
Okay, so when am I hearing this right, that when you're actually sitting in front of a panel, obviously going through your 25 cases,
Yep.
Which is your process stage number 3, as you say.
Correct.
You're there by yourself.
Well, you can have your, lawyer or someone there to support you, but you can't have. Basically, you walk in, I've described this in my article, that you walk in, and it is like this can happen in a federal magistrate court or in an office building where you're recorded, and you've got the committee members that's sitting across your the room like they're judges.